Thank you, everyone, for joining our panel discussion today on implications for the future of primary care. My name is Kristen McGovern. I'm a partner at Sirona Strategies and also executive director of the Partnership to Empower Physician-Led Care. I am joined here today by an esteemed group of panelists, and our format will be just to quickly have our panelists introduce themselves. Their bios should be available to you. And after brief introductions, we will go ahead and jump into the panel because we have 30 minutes. This is going to be an exciting discussion, and we want to get right to the substance. So I will start with you, Stephanie. Do you want to please go ahead and introduce yourself, and then we will just work our way down the list.
Sure. I'm Stephanie Quinn. I am the Senior Vice President of Advocacy, Practice Advancement, and Policy here at the American Academy of Family Physicians. Nice to be here.
Great. Steve?
Hi, Steve Sell, CEO of Agilon Health. We're a company that partners with independent primary care physician groups to move them from fee-for-service to value-based care for senior patients. Great to be here.
Excellent. Farzad?
Farzad Mostashari, co-founder and CEO of Aledade. Similarly, we're fellow travelers. We also work with all kinds of independent primary care practices across all types of payer contracts with a singular focus on taking global risk.
Excellent. And last but not least, Rushika.
Yeah, hi, I'm Rushika Fernandopulle. I'm a primary care doc. I'm co-founder and CEO of Iora Health, and now I'm Chief Innovation Officer of One Medical. We combined our companies a few months ago, and we've been building new model primary care practices that largely take risk and building a new model of consumer-centric value-based care. Great to be here.
Great, thank you. As I mentioned, we are going to save most of the time for discussion. If you found yourself here at this panel, that is because you are wondering how primary care factors into the future of healthcare, and specifically what role it plays in being the foundation of value-based care and really serving as a cornerstone for delivery system transformation going forward. So I will briefly just sort of frame up the discussion here, and then we will dive right into it. So as I mentioned, if you found yourself here, that's because you're interested in the discussion on primary care and the role it plays in value-based care success. The conventional wisdom, I think, is that primary care is the foundation of our healthcare system. That numerous thought leaders, numerous think tanks, foundations, bipartisan governments, members of Congress have all reiterated the important role of primary care in developing that doctor-patient trust, in healthcare system resiliency, and in achieving many of the goals that we have all been collectively working towards for decades, including increased quality and lower costs. So there are clear benefits to making primary care the foundation of our healthcare system and the foundation of our delivery system transformation efforts. And what is clear, and as you'll hear more from these panelists, what is clear is that the fee-for-service system that our healthcare system is largely based off of today, or has been based off of historically, just does not support fully leveraging the promise and value that primary care can bring to our healthcare system writ large. New payment and delivery models seek to untether providers from the fee-for-service treadmill and allow them to instead focus on patient-centric care that ensures patients have the care that they need to support them in their healthcare journeys. So we'll hear more a little bit about that. As has been discussed here already today, as part of its strategy refresh, Cmmi has set a bold goal of having all Medicare fee-for-service beneficiaries and the vast majority of Medicaid beneficiaries in accountable care relationships by 2030. And this will require many more patients to develop and sustain lasting primary care relationships. So with that framing in mind, we will go ahead and dive in and discuss collectively what will be needed, federal, state, private sector, across a wide array of entities and organizations to help Cmmi achieve this goal, to help our health system achieve this goal, and unlock the full potential of primary care for patients. So I will start by asking the panel for thoughts on why is value-based care the right platform to fully leverage primary care?
I can jump in. I think if we broaden our thinking, primary care really serves a lot of times as the quarterback in ushering care throughout the system. And so instead of looking at value-based care through this narrow lens of just extracting savings from the system, you need to think about really, really resourcing primary care on the front end to yield those services. I mean, fee for service is hostile toward prevention and wellness. And so it really puts physicians in receipt mode where they're waiting until people need care, until they're accessing it. Whereas if you look toward value-based care and proactively and prospectively resourcing them, they're able to actually manage a population. And I think population health is what we're after.
Yeah, Kristen, I'd state it even stronger. I actually think that if we don't change the payment model, primary care cannot do the job it can do. And that fee-for-service is the wrong way to pay for primary care. We should stop doing it. Primary care is about relationships, not transactions. And the second piece is we need to actually double down on primary care or more. Currently, with the current fee-for-service payment system, and because of the politics, the way that it's geared, primary care ends up with 4 or 5% of total healthcare spending. And we've all made bets that number ought to be 10 or 12 or maybe 15%. And that leads to better outcomes and actually lower total costs. It allows us to do a lot of things, be omni-channel delivery models. We can email and text and video and do home visits. It lets us be proactive and not just reactive. It lets us do population health from within the primary care practice because we actually know the patients, unlike other people who don't, and really just be creative in how to meet people's needs.
Yeah, I think when we started Aledade 7-8 years ago, we asked ourselves the question, like, we could play anywhere, right? Like, who do we partner with if we want to really have a business model where it's more profitable to prevent a stroke than to treat a stroke, which is my definition of value-based care, right? And even though the conventional wisdom at the time, and I'm glad, Kristen, you said that the conventional wisdom now that it's all about primary care, if you remember 7-8 years ago, the conventional wisdom was it's all about hospitals and health systems, and they're the ones who are going to win. And that never made sense to me because not only is primary care the best situated to get all the relationships that Rushika talked about to be able to access the data throughout the ecosystem, but from a financial alignment point of view, they have the most to gain and the least to lose from moving away from fee-for-service. And I think that's why primary care is that, is Archimedes' lever in moving the world.
Yeah, and Kristen, I would echo what everyone said. I think primary care physicians are the most precious asset that every community has in transforming care overall. The traditional fee-for-service system puts them at the bottom of that period overall, and value-based care moves them to the top. They can play the quarterback role that Stephanie talked about and coordinate that overall care. And when surrounded with the resources and the information and the time to spend in that relationship and spend most time with the most complex patients, they can have dramatic impacts on the overall cost quality experience. So I think there's a lot of data that supports that. I think it's how do we make that move, and value-based care is a fantastic starting point.
So Kristen, just one thing to add. We'd be careful what we mean by value-based care. I've read these crazy studies saying that 70% of payment is value-based payment. And most of that is these little dinky little bonuses on top of, tiny bonuses on top of typical fee-for-service. When I think the group of us on this call say value-based care, we mean real value-based care, meaning no fee-for-service, meaning going as far as you can, including and mostly to global risk, where you as primary care doctors are now responsible and have power to change total healthcare spending, not a little bit of shared savings, upside only, et cetera. So we'd be careful when you say value-based care, we really mean value-based care.
Great. Go ahead, Stephanie.
I was just going to say, I think we really need not look further than COVID-19. If we want to look for the use case for why the transition is needed, those that were in largely fee-for-service practices were unable to meet their patients' needs, and those who were being more prospectively paid were. And I think that, we really should take notice of that.
Great. And I think, so we have this tremendous asset, the primary care system workforce, and we have a system that doesn't value it or doesn't place it at the top through, put its money where its mouth is, as far as the policies that are needed to really make sure that we're able to fully leverage it to its potential. And Rushika, you mentioned that, all value-based care is not created equal, right? And all of you on the call have really, advocated for and are working every day and on policies and models that really seek to push the envelope when it comes to transforming the way that payment is made, the way that care is delivered, and sort of who and how is responsible for quarterbacking that care. So I think, sort of having established that we've got a great asset, it's not being fully leveraged, and we have a system that, by and large, the fee-for-service system is not working to maximize the potential. Can you all say a little bit about your models and what is needed to really, sort of flip the priority level here so that we are fully maximizing and really working within a system that really, does leverage. It's one of its greatest assets. I guess, Rushika, I'll start with you.
Sure. So I think probably the number one thing is aligning all the payers around this. So right now we're in a world where, and this is new, but where by and large Medicare Advantage insurers are now through some demos through Cmmi, we can get Medicare on board. The problem is for most practices, you're seeing Medicare and commercial patients and Medicaid and other. And it's really, and the right care model to take care of people under risk and to try and do population health is not a little different than the fee-for-service model. It's completely different. And it's really hard, and I would argue impossible, for practices to do both. And so what we need, I think, is increasingly all the payers, not just Medicare, but the commercial payers, the self-insured employers, Medicaid, to align by and large with these sort of risk-based payment models to allow us to actually take care of our whole population that way. I would think there's a lot more to say, but I think to me, that's the number one thing, is aligning payment among all payers.
Okay, so multi-payer alignment. What else do we need?
Yeah, I would say I think accessibility is a major factor. Making sure that there are models that are accessible to a smaller, less experienced practice. I mean, we need to be thinking about this on the spectrum of readiness and where skill building is needed. Where there are financial resources needed to make that pivot. It's not as simple as flipping a light switch as much as we would like it to be. And to echo what Rushika said, our members work with 14 or more payers on average. And so the level of differentiation between how they're approaching this really interrupts the workflow in a way that I would say interferes with their ability to deliver on what I believe to be a common goal of higher quality care at a lower overall cost.
Yeah, Kristen, I would add that I think to achieve the goal that you talked about, Cmmi, you're talking about 30 million senior patients incrementally. To do that, you're going to have to move a lot of communities that are 100% fee-for-service today into value-based care for the first time. And so I think you're going to have to create kind of an ecosystem within a community to enable that. And so we're focused on being a partner to these groups and allowing them to do that for the first time. That takes capital. That takes a team-based support in which in the office, they've got social workers and care managers, nurse practitioners, so that primary care physician can practice at the top of their license. And so I think that's super important. On the multi-payer side, we're going to work with 22 payers in 22. The majority of them have never done this before. So health plans are moving to this for the first time as well. And so this is not Southern California or Southern Florida in which it's very common. It's how do you make that move? And that's a critical step to be able to make that possible.
Agree with everything everyone has said. I'll add a couple more. So one thing is inevitability. When we moved, and I was U.S. National Coordinator for Health IT during a really steep upslope period. And the amount of money we actually put in, $28 billion, that was like Tuesday in stimulus payments. But we were able to get, basically every hospital and almost 90% of physician practices in America off of, using paper and pen to electronic health records. A much bigger transformation in their daily workflow than anything we've ever done before. And the way that happened wasn't the size of the checks. It wasn't even that there were huge penalties. It wasn't that there was the actual physical requirement, but there was the sense of inevitability. That this is happening. It's gonna happen. So you may as well do it sooner rather than later. There'll be more help for you if you do it sooner. And I think that's what we need, is that it's more than anything else. It's the federal government as well as the private sector, as well as purchasers, saying this is going to happen. This is fee for service is not going to be the way that you are going to be a thriving practice in the future. The second thing I'll say is that if we're in a bit of a hole, stop digging. And there are just some own goals right now that we are seeing from a regulatory perspective that are just tweaks that have to be made, where we're disadvantaging rural providers. Why would we disadvantage rural providers? We're disadvantaging providers who take care of majority dual disabled populations. Why would we do that, right? So there's some tweaks that could be made to the federal programs. And I would say also on the commercial side, like, why are you making a benchmarking approach, which is not going to be sustainable, where you have a full ratchet every time someone gets savings, you take it away from them. That's not going to be sustainable. So there's tweaks that have to be made if you want to make this, if you're really looking with an eye towards long-term sustainability. And then finally, I would say, I don't think we need more models. And I think all of us here have, one way or another, said this, right? We don't need 1,000 new models. There's models that now work, that we know work, and that is give primary care global accountability for total cost of care. That is essentially, if you look at all the results of the 50 plus pilots and the CM program and all that, like, the one that worked is when you give primary care responsibility for total cost of care and you help support them in doing that. So let's use the Medicare Shared Savings Program, in my view, as the platform. Maybe we need direct contracting for groups like Rushika's who don't have pre-existing relationships with patients, so they can be new entrants in this market. That's great. But we don't need new models. We need to really supercharge the models we have.
I think there's some naive and misguided calls to move backward from the progress we made with value-based care. I think those of us on this call have been doing this for a long time, well over a decade. And it's great. It's amazing the progress we've seen. I think, as Stephanie pointed out, COVID, if we didn't know this is the right idea, COVID showed this is exactly the right idea. Practices that were in fee-for-service fell by the vine because they couldn't do the right thing. There's some interesting anecdotal data that those of us who were doing value-based care were able to significantly treat our patients better with COVID and improve outcomes and reduce death rates, right? This is what we want as a country. I think there's some, obviously, as far as I said, there are a lot of rules that need to be changed and tweaked. These things are very complex. They're not perfect when you start, but the solution is to change the rules and improve it, not get rid of the programs and move backwards. We have to keep moving forward. And as Farzad said, we need to say this is going to happen, whether you like it or not, and everyone will do it. And it works. This is the direction we have to go in.
So, Rushika, what do you say to the folks who say fee-for-service is just easier? I just go, and I don't think it's doctors that are saying that for the most part. But how do you counterbalance that? Because there are some that say, value-based care adds complexity, or it's just easier to show up at the office and see my patient panel and bill, the office visit and go home. I mean, I think there are some clear value to the healthcare system for adopting value-based care models. And if we create opportunities for smaller, rural, independent practices, they can absolutely do it. But how do you respond to those critics? Or Steve, anyone on that?
Well, I think there's clear value for the senior patient and for the community. I think look at our organizations and look at the satisfaction levels that the patients have. Net promoter scores in the 80s, right? That's world-class anywhere, but in healthcare, that's fantastic. And it goes back to that patient-physician relationship. When you're able to move to that really intense relationship in which you're seen throughout, you end up with much higher vaccination rates in a period like COVID. You end up with far more touches. The net promoter scores for Agilon went up in our partners during 2020 and again in 2021, despite the craziness. And people said they felt cared for and they had somebody that helped guide them. If you're actually going to play that quarterback role, it's built around that relationship. And so I think it's kind of a no-brainer from a senior patient and from a community perspective, in addition to the benefits of lower costs and better quality experience.
I'll say, I mean, Rushika Rushika's group is approaching it from the standpoint of how do we create new primary care capacity in a new way. our approach is very much, Kristen, what, hand to hand, what you described, right? How do we go to a primary care practice, whether it's a 2-doc practice, literally, a solo practice, or a 5-doc primary care group, or a multi-specialty clinic, or a federally qualified health center? How do you go to them and say, change what you already have a business, change? And one of the things that we have found is actually the discussion has changed dramatically from the time when we were doing this 7-8 years ago, where at that time, like we were going to get the innovators, right? Those who were the first to do patient-centered medical homes, the first to do meaningful use, the first to have an EHR, right? Those are the people who were joining. And we've I was rereading Crossing the Chasm. We've moved now from this is only something that the visionaries are going to do and the innovators are going to do, to something that the pragmatists, right? You've made the leap when the pragmatist says, that guy got a $200,000 check for out of this, that's my entire take home. He doubled his take home from doing total cost of care contracts. What's the down? Okay, I'll do it. Right. That's where we really need that. That's where we are right now. I think in that inflection point is that we need to make this the standard. Right. It's not a scary, new, crazy idea. Right. It is the standard thing to do. Should become you're going to take as part of your portfolio. Right. You're gonna take total cost of care accountability, and you're going to have, proven people and methods and approaches and technologies that can get you there. Proven.
Yeah, Kristen, we need to design our healthcare system around a very simple thing, which is a better experience and better outcomes for our patients. In the end, if we don't actually make actual people healthier, this is all a waste of time, right? It's just a shell game. And I think it's very clear that the sort of primary care models we're talking about that allows you to give people health coaches and navigators and engage with them in a variety of ways is much better for patients. I think Stephen talked about net promoter scores that we all have. I think we all can point to lots better outcomes. And by the way, we lower healthcare costs, but that's a side effect, right, of doing this. So it is clearly better for patients. By the way, when doctors start working in these models, I think all of us experience, they realize this is better for them too. This is a much better way to practice. This is why I went to medical school, to be able to actually improve outcomes and not gin up bills for things that people want to get. There might be some docs who don't like that, but we shouldn't design the system around that. We should design the system around improving outcomes. And by the way, the physicians end up liking it better.
Mm.
And there is a very robust discussion around health equity in this country and a real reckoning. And it is impossible to deliver on that goal in the fee-for-service structure. Currently, those things that we know lead to greater health that occur outside the four walls of a physician's office are not billable in fee-for-service. Does that mean that those aren't worth investing in? Absolutely not. So I think we have to change our thinking in what our goals truly are. And if it is to reduce and eliminate health disparities, then we really do need a different approach.
So, Kristen, one point I just highlight that we've all touched a little bit is we need more primary care physicians, period. We need new models like Rushika in terms of where we're creating it. And we need to be able, like Farzad and our organization do, is take existing physicians and groups and payers and patients and move them into value-based care. That's going to allow us to sustain primary care and allow it to grow. We need to see more people coming out of medical school choosing adult primary care like you see in other parts of the world, but you're not seeing that, or at least you haven't historically. But we're starting to see far more people coming out of residency programs that are joining. I'd love to see people who've left medicine come back. We have that latent supply that we could tap around that. But this ability to bring in more primary care physicians and allow them to practice medicine the way they were trained, that Rushika talked about, is such a key element of that. And I think that's a combination of private and public solutions to enable that.
Great. So in our last 5 minutes, go ahead, Rushika.
I just want to highlight what Steve said. The limitation to all of our growth is actually primary care physicians, right? And I think like more people going into primary care. I think there's lots of data about primary care physicians burning out in the current model. A lot of data about people leaving and retiring, practices closing because they couldn't survive during COVID. We have an aging population. Our demand is only going to get higher. I think a real focus on how do we make it a more compelling place for people to go. That means, by the way, having people train in places like all of the places where we are and not in sort of, to be honest, crappy old school practices. And then maybe thinking about loan forgiveness for people going into primary care and a whole lot of other sort of public and private solutions.
I will also add, we've appropriately talked a lot about the physician side of this, but we've also had practices who during COVID, like laid off their nurses, who didn't have like people who could amplify and extend the work of primary care. Is not just physicians, it's a whole team. And the more that we can afford to extend and expand primary care capacity, like one physician was like, look, the urologist down the street is hiring PhD nurses, right? Like, I can't afford PhD nurses. Well, why not, right? Like, why can't we get to the point where it is, for a skilled nurse, advanced practitioners to want to do primary care rather than specialty, supporting specialties. I think that's another important way to expand primary care capacity.
So in our last 5 minutes, I want to do a rapid fire round. So we've identified the potential of primary care. We've strongly hit home that fee-for-service does not work to fully realize that potential. We've identified some barriers, some that are maybe bigger scale, like creating a sense of inevitability, and some that are more specific. We need more primary care workforce. We need multi-payer alignment. We need more opportunities or, leveraging existing opportunities more effectively to create opportunities for a range of providers, large and small, different practice settings, et cetera. Let's say you're CMS administrator for the day. What is the one thing that you do this year to help achieve the CMMI goal? And I'm putting you on the spot. Let's see, Steve, you want to go first?
I think you communicate a little bit of what Farzad was saying, which is there's going to be continuity, consistency, and predictability to a narrow set of programs. And for groups that for the first time are making this move, they can feel confident that the investment that's being made with partners like ours is going to be something that they can feel comfortable with and they can make that leap. I think that's the biggest single thing that would help.
So what I would say is in 5 years, we are no longer paying fee for service. It doesn't get us what we want to buy. So in 5 years, you either take you, and however you define you, will take total cost of care risk for this population, or you become someone to work with one of those people, but the fee for service option is off the table. Figure it out. And I think in 3, maybe you do it in 3 if you're ambitious, but I think it would take that sense of inevitability to move the market.
I would say accessibility, back to making sure that it's accessible to those that are maybe less skilled, less experienced. I mean, there are large portions of the country that models have not been tested. And so those capabilities need to be built. I think that there are very real revenue cycle management concerns that need to be addressed. And so CMMI looking into what it takes to get someone on that path, or, to get a practice onto that path, I think would really expedite not only the interest, but the ability, especially of those smaller practices.
When OMB asked for targets when we were running the Health IT Incentive Program, we gave them a number and we gave them a date. And the longtime civil servant who was my deputy said, you never do that in the federal government. Never. You can give them a number or you can give them a date. Never give them a number and a date. And I think that's what we need to do, right? We need to give a number and a date, right? And say, and it more near term, right? And say, we have 10 million people in MSSP this year. I want it to be 15 million next year and 20 million the year after. And now the mandate for the phenomenal team who's working in the Center for Medicare becomes, whoa, okay, I got to get to 15 million. All right, how am I going to do that? Right? Do I shorten the application period by 6 weeks? Probably not in that case, right? Do I make it harder for people, right? Do I think of ways in which rural communities can participate just as much? Can we think about a health equity angle where majority minority practices can also participate in this? Do we need to do outreach with HRSA to get, I don't know what the answers are as the CMS administrator. I don't need to know. I need to set the date and I need to set a number.
And build the skills in the meantime. All right. So there you have it. There you have. I think if any folks from CMMI are listening, we've got the solution on how you get to your goal in 2030, a number, a date, and build the skills and come up with a roadmap in the meantime. So I want to thank our panelists. I hope this has been a valuable discussion. I think there are certainly some key takeaways that we can all take into the future, into our work, and really generate that collective action that's needed on all of our parts to really bring primary care to the forefront and make sure that we're prioritizing those things that have the greatest potential to transform our healthcare system, like primary care. So thank you to my panelists for joining us here today, and we will continue with the rest of the program.